What is the definition of congestive heart failure? CHF. It's a clinical state of systemic and pulmonary congestion, both. And it actually results from the heart pumping disability. Heart is not able to pump the blood properly, resulting in the pulmonary and the systemic congestion. This is basically called as congestive heart failure. Two types: systolic, inability to pump the blood into the systemic circulation. This is the most common. And what is diastolic? Inability to receive the blood from the peripheral circulation, seen in constrictive pericarditis, hypertrophic cardiomyopathy and restrictive heart disease. Means here the heart is not able to receive the blood and here the heart is not able to pump the blood in the systemic circulation. Okay. So let's talk about the pathophysiology. It can be due to volume overload, it can be due to pressure overload, due to ventricular dysfunction, and other causes are the arrhythmia, pericardial disease, etc. Any left to right shunt, any valvular regurgitation like mitral regurgitation, aortic regurgitation, pressure overload, right-sided outflow obstruction is commonly seen in the etiology of Fallots. Ventricular dysfunction, L kappa, electrolyte imbalance, myocarditis, cardiomyopathy, and other causes of the arrhythmia and the. Now the compensatory response and their consequences. What will happen when the heart loses its ability to pump the blood? Okay. So there will be renal fluid, decreased cardiac output triggers three physiological responses. Okay. To aimed at restoring the perfusion of the body. First is the renal fluid retention, increased preload and cardiac output, but it causes, due to renal fluid retention, it manifests as the edema and pulmonary edema. Whenever there is heart failure, we usually get edema. So one of the causes of the edema in pediatric age group other than the nephrotic syndrome is renal fluid retention due to congestive heart failure. Okay. So next time whenever you see a edema, don't only think about the renal disease. Yes, renal disease is one of the cause, but there can be congestive heart failure. Renin-angiotensin vasoconstriction, which maintains the vital organ perfusion and it elevates the afterload and increases the myocardial work, causing cardiomegaly, hepatomegaly, raised GPP and poor perfusion. Okay. And there is sympathetic overactivity. When there is sympathetic overactivity, it increases the contractility and vasoconstriction, which raises the myocardial oxygen demand, manifests as tachycardia and S3 gallop. S3 gallop is one of the signs of congestive heart failure. Okay. So what is the etiology? From the fetal life, we can see there is fetal congenital heart block, tachyarrhythmia, severe tricuspid regurgitation, twin to twin transfusion, okay, restrictive foramen ovale and ductus arteriosus. After the birth of the baby, myocardial dysfunction secondary to birth asphyxia, hypoglycemia, hypocalcemia or sepsis. Any of the above causes can lead to myocardial dysfunction, which will lead to heart failure. Others are the tricuspid regurgitation, AV septal defect and cerebral arteriovenous fistula. Congestive heart failure with Epstein anomaly. Epstein anomaly, do you know what is the cause of the Epstein anomaly? One of the cause? Electrolyte, lithium, Epstein anomaly. Okay. Lithium is taken by the mother as a mood stabilizer. Lithium is used as a mood stabilizer in a psychiatric cases. And mother taking lithium, the fetus or the child will develop the Epstein anomaly. Congestive heart failure in the first few weeks of life, often preceded by the closure of the ductus arteriosus, okay, which can cause in healthy neonate due to sudden closure of the ductus arteriosus, it can cause life-threatening condition. So what to do? We have to check the peripheral pulses in both upper and lower extremity, lower saturation in the lower extremities, and right to left ductal shunting will be there, and low pressure in lower limbs. It is especially occurs in the cases of coarctation of aorta. VSD alone will not cause the heart failure. Okay. So look for additional causes like aortic stenosis, coarctation, AV regurgitation, multiple shunts, transposition and obstructive. VSD will cause congestive heart failure in the later part of the life. Means it will take 5 to 6 months or 8 months to develop congestive heart failure. Initially, alone VHD will not cause heart failure if the VHD is associated with any of the following like aortic stenosis, coarctation, AV regurgitation, then only it will cause congestive heart failure. Okay, then consider prematurity and the metabolic causes. Premature infants have poor myocardial reserve and PDA is one of the factor. PDA may cause congestive heart failure in first week of life. Okay, glycogen storage disease, adrenal insufficiency and neonatal thyrotoxicosis. Neonatal thyrotoxicosis can present, it is one of the cause, and we should remember it, neonatal thyrotoxicosis can also present with congestive heart failure. So the causes are divided into the different headings like arrhythmia, tachyarrhythmia, congenital heart block. Myocardial dysfunction causes like sepsis, electrolyte imbalance, there will in cases of the birth asphyxia, in cases of hypocalcemia, glycogen storage disease and endocrine disorders. And if there is in a structural heart defect like aortic stenosis, coarctation of aorta, hypoplastic left heart syndrome, obstructed TA PVC, transposition of the great vessels, these are also the causes of the cyanotic heart diseases. Obstructed TA PVC, TGA, these are cyanotic heart disease. In the recent exam, I was asking about the cyanotic and acyanotic heart disease. Various students failed to differentiate. VSD, ASD, PDA are all acyanotic heart disease. Obstructive TA PVC, transposition of great vessels, these are all cyanotic heart diseases. Now, after the first week of life, what are the causes? The most common cause is ventricular-septal defect, as I was telling, presenting around 6 to 8 weeks as pulmonary resistance falls. Okay, means VSD to it will cause pulmonary congestion and finally to right-sided heart failure. Okay, VSD left to right side, murmur will appear by the 1 week, but full congestive heart failure emerges by 6 to 8 weeks. Means it will take time, almost 2 to 3 months. PDA and aortopulmonary window also present like the similar findings. L kappa, anomalous left coronary artery from the pulmonary artery is rare. Anomalous origin of the left coronary artery from the pulmonary artery. Okay, present with myocardial infarction. There will be excessive crying, excessive sweating, and it is often misdiagnosed. Okay, and there are the other causes of the arrhythmia like tachyarrhythmia, complete heart block, hypoglycemia, hypocalcemia, and hyperthyroidism. Hyperthyroidism is one of the causes of the congestive heart failure in the first few months of life. Older children, what are the causes in the older children? Rheumatic fever, very common but less common in nowadays. Earlier it was a common, but now for every sore throat, even the quacks are prescribing antibiotics. So the chances of the rheumatic heart failure in recent decade, last 10 years has fallen quite a lot. Congenital heart disease, complicated by the anemia, infective endocarditis, okay, hypertension, systemic hypertension, contributing to the pressure overload, and finally leading to the cardiac failure. It will lead to left-sided heart failure, hypertension, and myocarditis and dilated cardiomyopathy. Okay, these are also the causes of the heart failure in the later months of life, means 5 years, 6 years, like this. So, what will be the clinical manifestation of congestive heart failure? There will be persistent tachycardia in neonates and older children. Tachycardia is one of the common findings. See, tachycardia and tachypnea are common. Okay, and in the younger children, means below 1 year, there will be feeding difficulty, effort intolerance, means the mother will complain that the child tires during feeding. दूध खेते खेते हापिए जाच्छे, ठीक है? This is the one of the complaint of the mother कि एकटू खानी खावार परी हापिए जाच्छे आर दूध खेते पारछे ना. So we can think about the heart failure in that case. There will be gallop rhythm in older children. Gallop rhythm is S3 gallop. Okay, घोड़ा देमनी दौड़ाए तेमनी ढक 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 एक आवाज आसे. This is the gallop rhythm. Excessive sweating on forehead during feeds. Edema, pedal edema in older children. S3 gallop. Raised JPP. Everyone was knowing it. Raised JPP amra during the examination we were discussing. And there will be poor peripheral perfusion, and in the older children there will be hepatomegaly. Congestive heart failure will lead to tender hepatomegaly and basal crepitations. Okay, diagnosis in infants require high index of suspicion. We can diagnose easily in the older children because we can see the JVP, we can look for the edema, we can look for the hepatomegaly, but in the Newborn age group, this we can guess about the heart failure from the findings like mother will complain of the feeding difficulty and excessive sweating during the feeding. খেতে খেতে হাঁপিয়ে যাচ্ছে আর খুবই ঘেমে যাচ্ছে. Infant sucks briefly, stops and then resume. This is the suck rest suck cycle, analogous to effort intolerance in older children. What is the treatment? Positioning and nursing. Okay. We have to keep the head end elevated so that the fluid is easily drained. Okay. Use judicious sedation and temporarily withhold oral feeds until and unless distress is subsided. Okay. To prevent aspiration. Because the patient will have respiratory distress, so we will avoid oral feeding until the distress subsides. Nutrition, infant with the congestive heart failure will require 120 to 150 kilocalorie per day, per kg per day. Nasogastric feeding may be required because the patient will have distress, so OG or NG feeding is beneficial than oral intake, direct oral intake. And we have to minimize salt intake in older children. Oxygen may worsen congestive heart failure in left to left side. Remember this. Okay, it will lead to pulmonary vasodilatation and may constrict the PDA in neonates. So we have to use oxygen judiciously. But if there is hypoxia, then we have to use oxygen also. What is the treatment? Treatment is we have to treat the precipitating events. Whatever there is arrhythmia, where there is electrolyte imbalance like hypocalcemia, or if there is any infection like sepsis, rheumatic heart failure is there, we have to treat the cause. Infective endocarditis, we have to give antibiotics. And if there is any drug toxicity like dioxin, so we have to treat for these. Okay. And what are the basically three pillars of medical management? Reduce the congestion. For reducing congestion, we have to use diuretics like furosemide, thiazide or spironolactone. It is the main treatment. Means we have to start with the diuretics. Then we have to increase the contractility. For the contractility, we have to give the drugs like dioxin, dopamine, dobutamine. All these increases the cardiac contractility. And we have to reduce the afterload. To reduce the afterload, we have to give the vasodilators like ACE inhibitors, nitroglycerin and nitroprusside. Means nitrates and ACE inhibitors. Diuretics in congestive heart failure. Okay, we have to start with the furosemide, very commonly used diuretic in the name of the Lasix. 1 mg per kg is the agent of choice for the quick relief of pulmonary and systemic congestion. Both in adult and pediatrics, we use the furosemide very oftenly. Okay, and for chronic use, the dose will increase 1 to 4 mg per kg per day, or we have to shift it to thiazide, 20 to 40 mg per kg in divided doses. We have to monitor body weight, blood urea and serum electrolyte at least twice weekly initially. Why? Because it will lead to hypokalemia. Furosemide leads to electrolyte disbalance. Okay. So we have to check for serum electrolytes and blood urea. Because hypokalemia, hyponatremia are the one of the more major concern. Okay. So if there is hypokalemia, we have to supplement potassium. If there is hyponatremia, we have to add sodium. And if there is refractory failure, combine diuretics with the different sites of action. Use IV rather than oral preparation. If there is refractory failure, means if the child is not improving the oral, we have to put the child to IV diuretics, IV Lasix, and we have to start the inotrope like dopamine at renal vasodilating doses at 2 to 5 microgram per kg per minute can be used. And then there is to increase the cardiac contractility, dioxin is very commonly used. The mainstay of treatment in the congestive heart failure in infants and children. We have to de-etalize at the dose of 30 to 40 microgram per kg orally, and maintenance dose is 8 to 10 microgram per kg in 2 to 3 divided doses. But what are the, we have to maintain a certain level in the blood, otherwise it will lead to toxicity. What are the signs of the toxicity of the digoxin? Prolonged PR interval of toxicity. There can be nausea, vomiting, and bradycardia and blocks are more common. It is very important. Okay. And so since bradycardia and arrhythmia are very common, we have to avoid in myocarditis. Okay. Other vasodilators which reduces the afterload are the ACE inhibitors. Basically these three drugs reduces the afterload and helps in the congestive heart failure. First is the ACE inhibitors, reduces afterload. What are the ACE inhibitors? Enalapril, very commonly used, and captopril. Okay. But we have to avoid in stenotic lesions, right? Renal artery stenosis and renal failure. Okay. the enalapril and captopril very commonly use ACE inhibitors, but in cases of the bilateral linear artery stenosis, we have to avoid them. Nitroglycerin, it is very safe and effective for the pulmonary edema. It reduces the pulmonary congestion, predominantly a vasodilator, okay. But we have to, since it dilates the blood vessels, we have to monitor the BP. And inotrope is added if hypotension develops. If along with the heart failure, we add nitroglycerin and there is hypotension, so then we have to add certain inotropes like dopamine and sodium nitroprusside. It is a potent arterial dilator. Nitroglycerin was a vasodilator and sodium nitroprusside is a arterial dilator. Dose is 0.5 to 1 microgram per kg per minute, and it is basically used in the acute LV failure, acute left ventricular failure with hypertension. Okay. What are the additional vasodilators or ARB? Nifedipine is often used in the cases of the hypertension induced congestive heart failure. Very commonly used calcium channel blocker. Very rapid action. It can be given sublingual as well. Hydrazine, it is less frequently used. So it is not that important in pediatrics. And another drug which is used is the angiotensin receptor blocker. But we use more ACE inhibitors than angiotensin receptor blocker in pediatric congestive heart failure. Okay. Example are the losartan, candesartan, valsartan, but these are not commonly used. We use enalapril and captopril more frequently than these. What are the inotropes? As discussed earlier, dopamine is very commonly used. We start with the renal vasodilator doses, 5 microgram per kg per minute. Then we can increase up to 10 microgram. Finally, maximum dose is 20 microgram per kg per minute. But it can cause arrhythmia. So before reaching the 20 microgram per kg per dose, we shift to epinephrine or norepinephrine. Okay. Dobutamine is another basic commonly used inotropes. Dobutamine is basically act on the beta receptor of the heart, beta 1 receptor of the heart. Okay. It increases the cardiac contractility and there is less frequent tachycardia. Okay. And other drugs are the epinephrine, norepinephrine and isoprenaline. And one drugs other than this is the milrinone. This is also used in the cases of the congestive heart failure. It is nothing but phosphodiesterase inhibitor with pulmonary vasodilating properties. Okay. Dose is 0.3 to 0.7 microgram per kg per minute. It is basically used in the refractory cases, because if after adding dopamine or after starting epinephrine, if there is congestive heart failure, then we add milrinone. These are the recent evolving therapies like L-carnitine. It is frequently used in the mitochondrial cardiomyopathy induced congestive heart failure. Prostaglandin E1 in neonate with a ductal dependent lesion like TGA, coarctation of aorta, aortic stenosis. All these we use PGE1 infusion at 0.5 microgram per kg per minute to keep the duct open. It is also used in the cases of the persistent pulmonary hypertension as well. Beta blockers, cardaverdiol, less commonly used, but these are the recent evolving drugs. L-carnitine is basically used in the cases of the metabolic cardiomyopathy, as I was saying, in cases of the mitochondrial cardiomyopathy associated with the carnitine deficiency. These are the advanced mechanical and surgical option. ECMO, you might have seen the word ECMO in the case of the COVID patient. ECMO support. Extracorporeal membrane oxygenation, excellent preoperative and postoperative support required for the congenital heart disease. This is basically used in the cases of the during the operative and postoperative stages of the heart diseases, like in case of any valvular repair, VSD আছে, ASD আছে, সেসবগুলো রিপেয়ার করার টাইমে পেশেন্টকে ECMO সাপোর্টে দেওয়া হয়। Biventricular pacing, this is used in the cases of the arrhythmia and congenital heart block. Okay. And left ventricular assist device and IABP, intra-aortic balloon pump. These are act as a bridge between the pediatric patient and the end stage cardiomyopathy to before transplantation. LVAD and IABP are used in the cases of the cardiomyopathy end stage patients requiring transplantation. Okay. And finally is the cardiac transplantation. It is basically the treatment of choice in cases of dilated cardiomyopathy, restrictive cardiomyopathy, hypertrophic cardiomyopathy. Any type of cardiomyopathy mostly are irreversible until and unless get treated with the cardiac transplantation. মিন্স কার্ডিওমায়োপ্যাথি হয়ে গেলে খুব বেশি কিছু করার থাকে না, তখন একটাই ট্রিটমেন্ট থাকে, উই হ্যাভ টু প্রথমে এলভিএডি এইসব ডিভাইস দিয়ে চালানো হয়, তারপরে ফাইনালি কার্ডিয়াক ট্রান্সপ্লান্টেশন। সো cardiac congestive heart failure in red cell, what is required? Early diagnosis and identify the cause. Early diagnosis like symptoms. In neonatal stages, mother will complain that বাচ্চা দুধ খেতে খেতে হাঁপিয়ে যাচ্ছে, বাচ্চার সোয়েটিং হচ্ছে দুধ খেতে খেতে, বাচ্চার ওয়েট বাড়ছে না, বাচ্চার ফ্রিকুয়েন্টলি কফ কোল্ড ইনফেকশন হচ্ছে, তখন আমরা সাসপেক্ট করতে পারি। ওল্ডার চিলড্রেন উই ক্যান লুক ফর দ্য পেডাল ইডিমা, বাচ্চার চোখ মুখ ফুলে যাচ্ছে, পা ফুলে যাচ্ছে, হ্যাঁ, বাচ্চা একটু দৌড়ালেই এফোর্ট ইনটলারেন্স হচ্ছে, হাঁপিয়ে যাচ্ছে, খেলতে পারছে না, তখন উই ক্যান ডায়াগনোজ কার্ডিয়াক মায়োপ্যাথি কনজেস্টিভ হার্ট ফেলিয়ার আর্লি অ্যান্ড আইডেন্টিফাই দ্য কজ। তো কজ আমাদের আইডেন্টিফাই করতে হবে। ফার্স্ট ইজ দ্য ডায়াগনোসিস, দেন ডায়াগনোস দ্য কজ। তো ইট মে বি ডিউ টু রুম্যাটিক হার্ট ফেলিয়ার ইন দ্য ওল্ডার চিলড্রেন, ইট ইন দ্য নিউনেটাল পিরিয়ড ইট ক্যান বি ডিউ টু আমাদের হার্ট সাউন্ড অস্কালটেট করতে হবে, যদি ভিএসডি পিডি এর মারমার থাকে তো সামথিং ভালভুলার হার্ট ডিজিজ আছে, যদি কোনো মারমার না থাকে তাহলে আমাদের ইকো করতে হবে। ওকে, আর ওল্ডার চিলড্রেনে যদি আমাদের রুম্যাটিক হার্ট ডিজিজের হিস্ট্রি থাকে তখন রুম্যাটিক হার্ট ডিজিজ সাসপেক্ট করে বাকি ইনভেস্টিগেট করতে হবে। যেমন যেটা কজ, যদি আমরা ইসিজি করতে হবে, যদি কোনো অ্যারিথমিয়া থাকে তাহলে অ্যারিথমিয়া ট্রিট করতে হবে, যদি কোনো ইলেকট্রোলাইট ইমব্যালেন্স থাকে লাইক হাইপোক্যালসিমিয়া থাকে তো হাইপোক্যালসিমিয়া ট্রিট করতে হবে। তো টাইমলি ইন্টারভেনশন করতে হবে। And if the timely intervention and proper treatment, মানে early start of the diuretics, early start of the ACE inhibitors like enalapril, captopril, so we can save the life. যদি একবার হার্ট ফেলিয়ার ইরিভার্সিবল স্টেজে চলে যায় বা একবার ডাইলেটেড কার্ডিওমায়োপ্যাথি থেকে হার্ট ফেলিয়ার অবধি চলে যায়, তখন বেশি কিছু করার থাকে না, তখন আর্লি টাইমলি ইন্টারভেনশন ইজ ভেরি মাচ রিকোয়ার্ড। And if the early timely intervention is done, the outcome will be very good. Okay, survival is determined by the early correction, যেটা বললাম the treatable cause. যদি ইনফেকশন থাকে ইনফেকশন ট্রিট করো, ইলেকট্রোলাইট ইমব্যালেন্স থাকলে সেই ইমব্যালেন্স ট্রিট করতে হবে, অ্যারিথমিয়া থাকলে অ্যারিথমিয়া ট্রিটমেন্ট দিতে হবে। আর যদি কোনো টিজিএ থাকে, অ্যালকাপা থাকে বা কোনো সার্জিক্যালি কারেক্টিভ লিসেন্স থাকে, তো আমাদের আর্লি সার্জারি করে তাকে পেশেন্টকে বাঁচাতে হবে। দিস ইজ অল। সেম থিং, রিকগনাইজ আর্লি। Feeding difficulty is the hallmark symptom of the congestive heart failure in the neonatal period. A specific etiology from metabolic structure in neonates to rheumatic heart disease in the older children and myocardial disease in the older children. Reduce congestion. Diuretics খুবই commonly and the main drug of choice to treat congestive heart failure. Okay, we have to reduce the congestion, increase contractility, ডিগক্সিন দিতে হবে, অ্যান্ড রিডিউস আফটারলোড দেওয়া রিডিউস করার জন্য এসি ইনহিবিটার্স অ্যান্ড ভ্যাসোডাইলেটার্স লাইক নাইট্রোগ্লিসারাইন, নাইট্রোপ্রোসাইড এগুলো। অ্যান্ড যদি সার্জিক্যাল কজেস থাকে তো ইউ হ্যাভ টু ট্রিট দ্য সার্জিক্যাল কজেস ভেরি আর্লি। সো দিস ইজ দ্য এন্ড অফ দ্য কনজেস্টিভ হার্ট ফেলিয়ার। এনিথিং, এনি কোশ্চেন্স you want to ask or you want me to repeat that topic, so I will repeat. So then we will move to hypertension. Usually hypertension is not that common in children or pediatric age group, and in pediatric age group hypertension is always and mostly it will related to some of the causes like maximum renal disease hote pare, like in post-streptococcal glomerulonephritis, PSGN treatment I was asking in the charts, PSGN treatment কিছু নেই, but you have to maintain the BP, ল্যাসিক্স, ডায়োরেটিক্স এগুলো দিতে হবে যদি PSGN থাকে। অ্যাডাল্টে যেমনি অনেক টাইম কোনো কজ থাকে না, অনলি ডিউ টু দ্য ন্যারোয়িং অফ দ্য ব্লাড ভেসেলস বাই দ্য ডিপোজিশন অফ দ্য ক্যালসিয়াম প্লাক, that cause is not in the pediatric age group. Pediatric age group hypertension is mostly related to renal diseases, and if not then some structural heart disease. So classification of hypertension, when we will call a child to be hypertensive, there is a specific cutoff, okay, for 1 to 12 year in means pediatric age group. The normotensive is less than 90th percentile, the BP is less than 90th percentile for the age and sex, means BP depends on the age, sex both, and height, age, sex, height, Okay. And adolescence, it is less than 120 and less than 80. When we will call it an elevated BP, if the BP of that child falls between 90 to 95th percentile of the age and sex. Okay. And if it is adolescence, then 120 to 129, and diastolic is 80 to less than 80. Systolic is 120 to 129. Stage 1 hypertension is 90 to 95th is elevated BP. More than 95th percentile is stage 1 hypertension. 95th percentile, or if it is less than 95th percentile plus 12 mg of Hg. Okay, means 130 to 139. It is 120 to 129, it is 130 to 139, and diastolic is 80 to 89. And stage 2 hypertension is more than 95th percentile plus 12 mg of Hg. Here it is less than 95th percentile plus 12 mm of Hg. It is for stage 2 it is greater than 95th percentile plus 12 mm of Hg or greater than 140/90. Here it is normotensive is less than 120/180. Less than 120/80. For elevated BP, it is 120 to 129. For stage 1 hypertension, it is 130 to 139. And for stage 2, it is more than 140/90. So, prevalence and diagnosis. Prevalence is hypertensive. Prevalence is 7% in Indian school-going children, and sustained hypertension, and mostly it is temporary, related to some like post-streptococcal glomerulonephritis is temporary, but sometimes it is sustained hypertension is only 4%. Okay, and it is higher in the overweight obese children, and boys are more affected than the girls. Okay. Diagnosis protocol: 2 readings per visit, confirm with the auscultatory method. Diagnosis requires 3 separate recordings at least once week apart. Means at least 3 recordings are required 1 week apart to confirm it as a hypertension. Ambulatory blood pressure monitoring is recommended if office blood pressure remains elevated for greater than 1 year or stage 1 hypertension persists over 3 visits. Ambulatory BP monitoring means during sleeping, during walking, every time the BP, continuous BP monitoring. If the patient is having stage 1 hypertension means 130/89, okay, because 140/90 is stage 2 hypertension. 130 to 139 and 80 to 89 is stage 1 hypertension. If the patient is having stage 1 hypertension for more than 1 year, so then we have to resort to ambulatory blood pressure monitoring. What is the screening schedule? Annual BP measurement for children above 3 years. All children above 3 years should be annually screened for BP. More frequent checks for the obese children, those on steroid, because steroid increases BP. Means usually a patient on nephrotic syndrome, we usually screen for BP. Okay, and coarctation history, if there is history of coarctation of aorta or diabetes. Children less than 3 years screened if there is congenital heart disease, if there is UTI, any malignancy or any transplant. So what is the usual schedule of screening is for children above 3 years, it is usually annually. বছরে একবার আমাদের বিপি মনিটরিং করতে হবে, বাট আমরা ফ্রিকোয়েন্টলি বিপি মনিটরিং কার করব যদি কোনো পেশেন্ট ওবিজ হয়, পেশেন্ট স্টেরয়েডে আছে, পেশেন্টের রিনাল ডিজিজ আছে আর কোয়াক্টেশন অফ আয়োটার হিস্ট্রি আছে, and if the child is less than 3 years, but if the child having congenital heart disease, then we have to screen early for the BP. Otherwise less than 3 years child usually don't screen. Then primary or secondary hypertension. Primary is essential hypertension, এটা বেসিক্যালি অ্যাডাল্টসদের দেখতে পাওয়া যায়, অ্যাডাল্টদের আমাদের হয় এসেন্সিয়াল হাইপারটেনশন, আর সেকেন্ডারি হাইপারটেনশন ইজ মোর কমন ইন দ্য পিডিয়াট্রিক এজ গ্রুপ, লেখা আছে predominantly in the 6 to 12 years old or adolescent, especially with the family history of hypertension. Overweight or obese, screening in obese patient should include HbA1c for metabolic screening. HbA1c is nothing but glycosylated hemoglobin, 3 মাসে একবার চেক করা হয়। লিপিড প্যানেল, সিরাম ক্রিয়েটিনিন অ্যান্ড লিভার। আমরা গ্লাইকোসাইলেটেড হেমোগ্লোবিন কেন 3 মাসে একবার চেক করি, কেউ বলতে পারবে? HbA1c অ্যাডাল্টদের কেন 3 মাসে একবার চেক হয়? হ্যাঁ, দ্যাট ইজ দ্য কজ। RBC লাইফ স্প্যান ইজ 90 to 120 days. সো গ্লাইকোগ্লোবিন আমরা 3 monthly চেক করি। Extensive secondary evaluation is not required if family history positive and no secondary cause is suspected. অনেক ফ্যামিলিতেই হাইপারটেনশন আছে, তার মানে এই নয় কি প্রতিটা বাচ্চারই আমরা ভাববো কি এর হাইপারটেনশন হয়ে গেছে। বাট ইফ দ্য চাইল্ড ইজ ওবিস, তার সঙ্গে ওর কোনো লিভার এনজাইমসের প্রবলেম আছে, ওর লিপিড প্রোফাইল রেজড আছে, দেন উই হ্যাভ টু স্ক্রিন এভরি অ্যানুয়ালি অ্যান্ড উই হ্যাভ টু লুক ফর অল দিস প্যারামিটার্স। কেন কি দিস ক্যান লিড টু হাইপারটেনশন। কোনো সময় হাইপারটেনশন যদি এখন নাও থাকে, হয়তো 6 মাস পরে হাইপারটেনশন ডেভেলপ করতে পারে বা 1 বছর পরেও ডেভেলপ করতে পারে, যদি কোনো পেশেন্ট ওবিস হতে পারে আর তার সঙ্গে তার ফ্যামিলি হিস্ট্রি হাইপারটেনশন আছে। সেকেন্ডারি হাইপারটেনশন যেটা আমি বলছিলাম, আদারওয়াইজ এসেন্সিয়াল হাইপারটেনশন ইজ ভেরি লেস কমন ইন পেডিয়াট্রিক এজ গ্রুপ। আমাদের যেটা হয় পেডিয়াট্রিক এজ গ্রুপে হচ্ছে সেকেন্ডারি হাইপারটেনশন, মোস্ট কমন ইন চিলড্রেন লেস দেন 6 ইয়ার, অ্যান্ড যেটা বলছিলাম রিনাল অ্যান্ড রেনোভাস্কুলার ডিসঅর্ডার অ্যাকাউন্ট ফর 63 to 74% অফ দ্য কেসেস। আমাদের বলাই থাকে কি ইফ দ্যার ইজ হাইপারটেনশন ইন দ্য পেডিয়াট্রিক এজ গ্রুপ, তো প্রথমে চিন্তা করতে হবে কোনো রিনাল ভাস্কুলার ডিজিজ আছে কিনা। কেন কি আদারওয়াইজ যেটা অ্যাডাল্টসদের যেটা এসেন্সিয়াল হাইপারটেনশন হয় সেটা পেডিয়াট্রিক এজ গ্রুপে হয় না ইউজুয়ালি। সেকেন্ডারি হাইপারটেনশনটাই মোর কমন। হ্যাঁ, আর তার জন্য যদি কোনো বাচ্চার আমরা দেখি পারসিস্টেন্ট এলিভেটেড বিপি আছে, তো আমরা we look for the renal artery stenosis, we look for the coarctation of aorta, we look for the hormonal causes, aldosterone level আমরা টেস্ট করি, ACTH level টেস্ট করি। If there is elevated diastolic BP is more, okay, then it is predictive of the renovascular disease and renal ultrasound is warranted. যদি আমরা দেখি পারসিস্টেন্ট ডায়াস্টলিকটা বেশি বাড়ছে, তাহলে আরও কনফার্মেটরি টুয়ার্ডস দ্য রিনোভাস্কুলার হাইপারটেনশন। তখন আমরা ইউএসজি করি, আমরা ডপলার করতে পারি, হ্যাঁ, ডিফারেন্ট আদার ফাইন্ডিংস আমরা বার করি। মিনস পেডিয়াট্রিক এজ গ্রুপ পেশেন্টস হাইপারটেনশন ইজ মোস্টলি রিলেটেড টু দ্য রিনাল ডিজিজ ইফ নট প্রুভেন আদারওয়াইজ। টু টার্মস, এটা মেডিসিনও পড়া হবে, হাইপারটেনসিভ আর্জেন্সি অ্যান্ড হাইপারটেনসিভ এমার্জেন্সি। ওকে, what is hypertensive urgency? Severe BP elevation without signs of end organ damage, that is urgency. Requires a slower controlled reduction of BP over 24 to 48 hours. আমরা অলওয়েজ বিপি মনিটরিং করব, আর একবারে বেড়ে গেছে বলে হট করে বিপি কমাবো না। উই হ্যাভ টু রিডিউস অ্যান্ড কন্ট্রোল দ্য বিপি ওভার রিমেম্বার 24 to 48 আওয়ার্স। অ্যাডাল্টদের ক্ষেত্রে এটাই চলে। র্যাপিড রিডাকশন রিস্ক দ্য ইসকিমিয়া অ্যান্ড ইনফারশন। And what is hypertensive emergency? Hypertensive emergency তে কি হবে? There will be end organ damage. Hypertensive urgency, এখনো urgency আছে কিন্তু emergency হয়নি। Urgency, there will be no end organ damage. When there will be end organ damage, then there will be emergency. Severe BP elevation with end organ damage. Hypertensive encephalopathy, acute left ventricular failure, myocardial ischemia, papilledema, elevated liver enzymes, and in this case it requires immediate BP reduction. That is, targeted BP reduction is 25% reduction over 6 to 8 hours because there is end organ damage. So immediately আমাদের অ্যাকশন করতে হবে। Rapidly decreasing BP can reduce oxygen organ blood flow, causing ischemic ascent and infarction. So we have to gradually reduce the BP. But if there is hypertensive emergency, যখন emergency হয়ে গেছে, end organ damage হচ্ছে, then আমরা সম্পূর্ণটা রিডাকশন করব না, but 25% of the reduction over 6 to 8 hours. That is our target. In hypertensive urgency, we have to control BP over 24 to 48 hours. Why? Because rapid reducing BP can reduce the organ blood flow, which will lead to ischemia and infarction. What is the stepwise management? Elevated BP আছে, elevated BP is 98 to 95th percentile. Lifestyle modification, আমরা খেলাধুলা করতে বলবো, তাকে less fatty foods consume করতে বলবো। Recheck at 6 months. Recheck for and check for all the 4 limbs BP and continue lifestyle modification. Okay. If there is stage 1 hypertension, means BP is 95th to 99th percentile. Then after lifestyle counseling, আমরা 1 to 2 weeks পর আবার চেক করব। Here we are checking every 6 monthly. And check upper limb and lower limb BP. Initiate nutrition weight management. After 3 visits, order for ambulatory blood pressure monitoring and conduct the diagnostic test. এখানে আমরা বেশি ডায়াগনস্টিক টেস্ট কিছু করাচ্ছি না, কিন্তু এখানে যদি পারসিস্টেন্ট দেয়ার ইজ বিপি বিটুইন 95th to 99th percentile, then we will do lipid profile, will do LFT, hormonal test, renal angiotensin level, aldosterone level, ACTH level, এরকম সব করি এগুলো, and consider treatment যদি persistent rise in BP থাকে। Stage 2 hypertension, immediately start antihypertensive. Here we are not starting, we are waiting, we are first allowing for lifestyle modification. We are telling the patient to do proper exercise, consume less fatty foods. We are conducting the diagnostic evaluation. Then only we are treating the patient. But here if there is stage 2, means 99th percentile and above, is if the BP is more than 99th percentile, then we have to start antihypertensive immediately. Remember it. Identify underlying causes, and then you have to do echocardiography as well to see the left ventricular hypertrophy before starting any pharmacological treatment. What are the points in the lifestyle intervention? DASH diet. DASH diet you might have read in community medicine as well. This is nothing but high fiber diet. Dietary approach to stop hypertension is increase foods, vegetables, grains, low in sodium and fats. Exercise. How much exercise? This is also, I think you have read in community medicine. 40 minutes of moderate aerobic activity 3 days per week. Daily করতে হয় না, ওখানেও লেখা আছে, এগুলো কমিউনিটি মেডিসিন আমরাও পড়েছি, হয়তো তোমরাও পড়েছো। 40 minutes of moderate aerobic exercise 3 days per week. Counseling, motivational interviewing and behavioral counseling to support adherence to lifestyle modification. Means counseling করতে হবে কি বাচ্চাকে ডেইলি এক্সারসাইজ করাতে হবে, খেলাধুলা বেশি রাখতে হবে, ফ্যাটি ফুডস কম খাওয়াতে হবে, প্যারেন্টসের কাউন্সিলিং, বাচ্চার কাউন্সিলিং, ফাস্ট ফুড খাওয়ানো যাবে না, এইভাবে। টার্গেট বিপি, রিডাকশন ইন সিস্টোলিক অ্যান্ড ডায়াস্টোলিক বিপি to less than 90th percentile, 130 to 130/80 in adolescents greater than 13 years. What are the first and second line pharmacotherapy? First line agents are the for CKD, proteinuria and diabetes, ACE inhibitors, very commonly used, captopril, enalapril, lisinopril, ARB, candesartan, losartan, valsartan, and long acting calcium channel blockers, amlodipine and nifedipine is short term only. It is for hypertensive emergency, nifedipine is used. We mostly resort to amlodipine. আমরা commonly use করি amlodipine use করি, আমরা use করি enalapril use করি, or losartan use করি। এই 2-3টে ড্রাগ আমরা commonly use করি যদি পেশেন্টের CKD along with proteinuria or diabetes থাকে, then first line are these agents. What are the second line agents? For we use the diuretic like thiazide, chlorothiazide, chlorothalidone, beta blockers, ethanol, metoprolol, and alpha blockers, but these are less commonly used. আমরা যেটা ইউজ করি most commonly আমরা এগুলো ইউজ করি, as because most of the pediatric age group patients having hypertension associated with the renal disease, proteinuria, post-streptococcal glomerulonephritis হয়, তো তখন আমরা এইগুলো দিয়ে আমরা hypertension কন্ট্রোল করি। These are less commonly used. যদি আমরা কোনো heart disease পাই, congestive heart failure এর কোনো cause পাই related to means cardiac like cardiomyopathy and all, then আমরা এই beta blockers or alpha blockers use করি। These are the medications, labetalol, IV infusion চলে, nicardine, esmolol, beta blocker, sodium nitroprusside, hydroxyzidine, enalapril, এগুলো কিছু না, এগুলো বেসিক্যালি পরবর্তীকালে লাগবে, এখন লাগবে না, ডোজগুলো মনে রাখার এখন কিছুই দরকার নেই, শুধু ড্রাগসের নাম মনে রাখলেই হবে। So what are the key takeaways? Screen early, annual BP checks for all children greater than 3 years. বললাম, more frequent check for high risk patient like obese, renal disease, the patient on steroid, diabetes, coarctation. Confirm with the, if there is then we have to confirm with the ambulatory blood pressure monitoring, is essential for confirming hypertension. Ruling out white coat or masked hypertension. White coat hypertension, you know, na? After coming to doctor's chamber, the patient is having hypertension. It is due to the anxiety. Patient ভয় পাচ্ছে বলে ডক্টরের সামনে এসে ওর হাইপারটেনশন, দ্যাট ইজ হোয়াইট কোট হাইপারটেনশন। সো টু রুল আউট হোয়াইট কোট হাইপারটেনশন আমরা 24 আওয়ার্স বিপি মনিটরিং করব, অ্যাম্বুলেটরি ব্লাড প্রেশার মনিটরিং, অ্যান্ড লাইফস্টাইল চেঞ্জেসটা খুব ইম্পর্টেন্ট। ফার্স্ট is lifestyle, then only drugs when needed. যদি lifestyle after lifestyle modification, if the patient is still having high BP, then only resort to drugs. DASH diet means high fiber, low carb diet. Okay. Aerobic exercises, first line 40 minutes of exercises for 3 days per week. Pharmacotherapy targets BP less than 90th percentile. Okay. Stage 2 hypertension requires immediate treatment and subspecialty referral. Means যদি আমরা stage 2 hypertension হয় তো আমরা ড্রাগ স্টার্ট করব, then we will refer the patient for echocardiography to a cardiologist. Okay. So these all in case about the hypertension. Hypertension এর ক্লাসিফিকেশনটা মনে রাখতে হবে, কোনটা স্টেজ 1, when we will call it stage 2, what is elevated BP and what is normotensive. Normotensive is less than 90th percentile, means less than 120/80. What is elevated BP? 98 to 95th percentile, means 120 to 129. Systolic, diastolic is 80 only. What is stage 1 hypertension? Stage 1 hypertension is 95th to 99th percentile, means the BP will be 130 to 139 and diastolic is 80 to 89. What is test to hypertension? More than 140/90. Okay. Hypertensive urgency is elevated BP without end organ damage. Hypertensive emergency is, when we will call emergency, when there will be end organ damage. So elevated BP with end organ damage is hypertensive emergency. Elevated BP without end organ damage is hypertensive urgency. Urgency is there is elevated BP but no organ damage. So urgency, we are having urgency, but emergency means emergency, means there will be end organ damage. In the case of emergency, we have to immediately do reduction of 25th percentile of the blood pressure. Present blood pressure হচ্ছে 25% কমাতে হবে in next 6 to 8 hours. But in case of hypertensive urgency, we have to reduce BP over 24 to 48 hours. Why rapid BP reduction is not advised? Because rapid BP reduction will lead to reduced perfusion and it will lead to ischemia and infarction. So to avoid the chances of the heart ischemia or infarction, stroke বা heart attack prevent করার জন্য আমরা BP reduction over 24 to 48 hours করি. But if there is emergency, then we have to reduce 25% of the elevated BP in next 6 to 8 hours. What are the drugs? Most commonly used drugs are the diuretics, ACE inhibitors like enalapril, captopril, and calcium channel blockers like amlodipine. These all. Okay, 2 topics are over. Hypertension e karo kichu, anyone anything you want to ask or you want to know, you can tell me. In hypertension, essential hypertension is not present in the pediatric age group. Pediatric age group patients mostly present with hypertension having renal background, মানে তার জরুর মানে ম্যাক্সিমাম ক্ষেত্রেই তার কোনো রিনাল ডিজিজেস চান্সেস ভেরি হাই। মানে বাচ্চাদের বিপি বেড়ে যাওয়াটা ইউজুয়াল ফাইন্ডিংস নয়। যদি বাচ্চার বিপি বাড়ছে তো আমরা তার কোনো রিনোভাস্কুলার ডিজিজ লাইক রিনাল আর্টারি স্টেনোসিস, হ্যাঁ, এসব কিছু আছে কিনা, আর কোয়াক্টেশন অফ আয়োটা, মানে আইদার রিনাল বা হার্ট ডিজিজ আছে কিনা চিন্তা করতে হবে। ঠিক আছে, ওকে, থ্যাংক ইউ।